Next on call, fighting colon cancer.
I'd developed some lower back pain.
And the recommended regular screening.
Funding for this program is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Television.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
There's the valve.
All of them together.
And which was healthier, the yogurt and the bagel?
All right, I'm going to start by measuring the size of it.
You could also add grilled chicken to this recipe.
Blow hard, blow, 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 keep pushing.
Just your head.
Pull red handle to open bag.
Hello and welcome to On Call. I'm Tammy Watson. March is National Colorectal Cancer Awareness Month, and tonight on our show it's going to be about colon cancer prevention and intervention. Coming up, you'll meet a man undergoing treatment for colon cancer, and later in our show, you'll go inside the exam room with our medical editor, Dr. Rick Holm, and find out about one of the most recommended methods for screening for colon cancer. And of course, we have our doctors live on set right now, ready to answer your questions about colorectal cancer. Joining me in the studio tonight are Dr. Scott Baker, Dr. Cristina Jensen, and On-Call medical editor, Dr. Rick Holm. Our phone number is 1-888-DOCTOR-ON-CALL. Again, that's 1-888-376-6225. And helping answer the phones tonight are volunteers from the South Dakota State University Pre-Professional Science Club and the SDSU Nursing Student Association. Dr. Holm, before you introduce our guests, you're actually helping out with an effort by the Brookings Health System to promote awareness of colon health issues this month. Why is this so important?
Well, really, my father died of colon cancer.
I'm sorry, I didn't remember that.
You didn't remember that, did you? It's a very important issue to me that people don't have to suffer his fate. And I think prevention is worth a pound of cure. So if I can help anyone not have to go through that, it would be a good thing. And it just, I don't think that people love to have colonoscopies, but it's really nice to know that there isn't cancer up there. So the idea of living a full life and not having to face colon cancer is a very good thing, and that's what it's all about. So this last Monday of March at the Taste of Europe in Brookings, we're going to have a free kind of a seminar, and everybody's invited to come, and I'm going to give a little blurb, and we'll show a colonoscope, and then we're going to ask a volunteer in the audience. No, just a joke.
You get a tagline. It's preventable, it's treatable, and it's curable.
Yes, preventable, treatable, curable. So first or the last Monday of March at the Taste of Europe in Brookings, if you'd like to join us. I think it's 7:30. It might be 7, so you should call a hospital and find out.
Yep.
So I'm very pleased to introduce to you our guest for this evening, Dr. Scott Baker from the Surgical Institute of South Dakota in Sioux Falls, and Dr. Cristina Jensen from the Avera Gastroenterology Clinic, also from Sioux Falls. Welcome, the two of you.
Thank you.
Nice to have you here. Well, Scott, you are a colorectal surgeon, and you've had special training. Tell us about yourself. Where did you grow up? Where did you train? What's this colorectal surgery all about?
Yeah, so I grew up in Sioux Falls. Went to Lincoln High School. I went to college in St. Cloud. I went to medical school at USD and then did general surgery residency, which is 5 years of surgery residency in Pennsylvania at the Guthrie Clinic. Came back and practiced as a general surgeon for 3 years and then decided that I was really interested in colon cancer and decided that a colorectal fellowship was in my future, so I went back and did a colorectal fellowship, which is an extra year of training, and I did that in Columbus, Ohio.
Okay. And you've been here in South Dakota doing colorectal surgery for 2 years, 1 year?
This is my second year, going on third year.
Good. Yeah. Okay, so welcome. And
Thank
we sure think this guy can answer those questions.
Yeah,
about
we're going to find out something.
And Cristina Hill, now you, where did you grow up?
I grew up in Brookings.
You grew up in Brookings.
Yes,
Go figure.
I did.
How about that?
Yes.
And some of your earlier experiences with sort of some old codger, or who was
yeah,
that?
no, you were definitely a mentor to me starting off in college. So through college, through medical school. And
So you had the early, what was the special scholarship?
medical alumni program. So I knew from a young age I wanted to be a physician, and I was able to get into medical school and pursue that.
But part of you had to spend some time with some guy.
I had to spend 6 weeks with Rick. So yes, and boy, I was tired at the end of the day because you had boundless energy, but it was a great experience and helped me to go into internal medicine, and I did that. And then I grappled with the idea of staying in internal medicine, but decided to go on and do 3 more years and did a gastroenterology fellowship.
And where did you do that?
Well, I started at Tulane University down in New Orleans, but after Hurricane Katrina, I got relocated to the University of Iowa.
You were there when the Katrina hit.
Yes, I sure was.
And what was that like?
Well, luckily I did evacuate the day before, but it was a horrible experience for my patients, my colleagues, and the city still hasn't recovered, unfortunately.
No.
I mean, it's on its way, but it'll never be the same. But I was fortunate to end at the University of Iowa and very happy to be there.
And now you've been practicing gastroenterology in Sioux Falls
About
for
3.5 years now.
So, well, great. We've got a gastroenterology internist and a colorectal surgeon right here in the midst of us to answer your questions. So give us those calls. We'll be right back after this.
In the United States, approximately 160,000 new cases of colorectal cancer are diagnosed each year.
Between the years of 2004 and 2008, there were about 430 South Dakotans each year diagnosed with a new case of colon cancer. One of those individuals is Steve Myers from Brookings, South Dakota, and here is his story.
Just like yesterday, and it was how many years ago? 38 this year?
I think so.
When Steve and Kay Myers were married, like most young couples, they didn't know what life had in store for them. Today, they know that their journey together has been one filled with family, faith, friends, and, beginning 6 years ago, cancer.
Well, we were both 55 and thought it was time to have a colonoscopy, just a routine, and I went first and told him nothing to it. You can do it, Steve. And so I was kind of the cheerleader there. And he said, okay, yeah, I'll get that appointment. Well, then one thing happened and another and put off.
Steve did eventually make time for his screening colonoscopy, though, and the results were a surprise. He had colon cancer.
We were really shocked because there were absolutely no symptoms, no problems.
Steve promptly had surgery, which removed a third of his colon, and he moved on to additional treatment.
We did 6 months of chemotherapy, and then monitored it because we got a clean bill of health after the chemotherapy, and that went on well for 4.5 years. We got consistent cleans, and then I developed some lower back pain a year ago in January, and that's kind of when we started down the journey again.
Steve's cancer had reappeared. Low back pain was actually determined to be a symptom of this.
Didn't really know for several months what was causing the problem, but then we finally got in and figured it out in about June, and then we started another regimen of chemotherapy last July of 2010.
The chemo had contained it. It had not spread anyplace else. It was doing okay, but we just felt like maybe there was something more we could be doing. And we went to Mayo, and they do have a new program. They want to be very aggressive. They said since it had not spread to any other major organ, and it's right there located in the back, that they are going to go after it with radiation for 5 weeks along with the chemo, and then give his body a month to rest, and then surgery. We're excited, we're anxious. I guess looking forward to 3 months from now when it's all behind us.
Kay has set up a website to keep family and friends abreast of Steve's treatment, and according to Steve, loved ones are an important part of making it through these difficult times.
There's a tremendous amount of support out there with friends, family, faith, all of those, I think, enter into this journey that you're on too. When you get involved, you'll find out that you're not alone, that there's a lot of people that are either going through it or have experienced some form of cancer in their family or themselves.
On this journey too, I guess I would just tell people to, listen to your body, but also take precautions. I mean, don't wait for something to happen. Don't wait for that pain in your stomach or, blood in your urine or whatever, get regular checkups and, be aware of what's going on.
Steve and Kay are currently at the Mayo Clinic in Rochester, and we want to wish them well as Steve proceeds through his treatment. Doctors, no symptoms. That's, kind of how the story started with Steve. How common is that?
It's the most common presentation of colon cancer, unfortunately.
It's nothing.
Nothing.
So
normal. Feel fine. No change in bowel habits, no blood in the stool, nothing. Feel good. No trouble.
And then it's already an issue at that point? So
well, sometimes you catch it where it hasn't spread, and sometimes you don't get spread. So that's why we make that at 50 years, get your first one, unless there's a strong family history, and then you want to get it at 40 or earlier even, depends upon the scenario.
Well, let's talk about colonoscopies. What do you want to get everybody to know?
What's your comment about colonoscopies?
Please don't be afraid of them. Everyone comes in, well, I had my cousin who said that this happened during their colonoscopy, and sometimes bad things do happen, but the majority of cases are so safe. People do very well throughout colonoscopy, and it's an outpatient procedure. You're in, you're out. And, we can save lives with it. And so the embarrassment factor, it's real, but, we're professionals, what we do every day, and literally, we can prevent cancer here. So.
Yeah. Well, and I drape the guys. I mean, the only thing that's shining out there is those two little moons, and that's off, And the room doesn't see anything else, and there's a picture of his colon, and that's all, that's it. Scott, do you have any comment about?
No, I would reiterate the same comment that I think that the bonus of this is that it's totally preventable. Colon cancer is preventable, and it's minimalistic, embarrassing. The day of the colonoscopy, the worst probably is the night before, the bowel prep, and you do that in your own home in the confines of your own home. So there's really no reason not to do it.
Well, the prep, though, it's like you hear all these horror stories. They're going to make you drink this medication, and you're going to have horrible diarrhea, and you're going to be miserable, and then the next day you go, and they're sticking a scope up your behind. Is it like that?
Having had 3 of them, and I have had polyps. I don't know if either one of you have had your colonoscopy yet.
No. Not yet.
You're not old enough. You're not old enough. But I can just tell you that I've tried drinking the gallon of, paradoxically called Go Lightly, which makes you nauseated, and I have taken the phosphate soda, which was now removed from the market because of the danger to the kidney. And now we're using magnesium citrate. I think you guys might be doing the Go Lightly yet. I don't really know.
Go Lightly, there's a half-gallon preparation. For some individuals, there's even a pill prep form. We have to do that in very selective individuals. And then the newest and greatest prep is a new 2-cup prep as well. So there are more options out there. It's just that the person takes the prep the correct way so we can get the absolute best results.
It's not great when you go up there and it's just everything is covered by fecal residue. You'd just like to have a good view.
Well, yeah, because it's...
And we use the mag citrate, and it works great,
I like to use a prep called movie prep. Another enticing prep to see if they'll drink it. Oh, that's right.
Where did they get that name, I wonder?
That's right. I don't know.
Something moves.
It moves.
But, okay, so what can make prep easier? I'm going to,
There are several things that make it easier. There's something called split dosing now where you You take half the dose the night before, the other one's 4 to 6 hours before the colonoscopy, and that makes it somewhat easier for the patient, and it also helps the colonoscopist to see the colon clearer because there's less likely for liquid to come from the small bowel into the colon.
Okay.
Other techniques, keeping it chilled on ice, using a straw, using crystal light packets to flavor each glass, little things like that that our nurses can go through with the patient to make it more tolerable.
Okay, I want to ask you a question. If I wanted to try and get a jump on things, should I be eating like a good fiber diet to move things through beforehand, or should I be like trying to eat soup and light stuff for a day or two?
Liquids.
Clear liquids.
We generally and successfully have a really good preps by having them on clear liquids the day of the prep. The night before the procedure, with the day full of clear liquids, they take their first bottle of mag citrate, and the next morning the second bottle of mag citrate. Right. And if they're still not clear, then we give them a soap suds enema before the procedure. And we just have not had a failure like we used to have. It just cleans them out. And but the clear liquid. Do you guys go clear liquids the day before?
Right.
I have one lady who. She takes 2 or maybe 3 days of clear liquids. She just has a slow, sluggish bowel. Nice lady, healthy in every other way, but aggressive prep the second time because she was just not cleaned out. Still not cleaned out. This third time, 3 days of clear liquids, 2 days of prep, and she was pretty well cleaned out. That's just amazing. It's variable.
Right.
Mm-hmm. And the answer is, that was the most miserable thing, taking that crap, or what's wrong with that? I had no problem. I kind of feel lighter. It's not so bad. I mean, so what?
Depends, and it's not okay.
So it's variable.
Right. And when you consider the split dosing, taking the dose 4 to 6 hours before the colonoscopy, a lot of people come for early morning colonoscopies at 8 o'clock, and that puts them somewhere in the middle of the night. They have to wake up and take the prep, and I think that's the same mentality that, well, I'd rather do that than have to do it twice or 3 times. So,
Absolutely.
Okay. Well, and now to the crux of the matter, the reason why getting your colon empty is so important is because it's kind of a visual exam. It's what you can see with the camera.
You see every nook and cranny of the colon, so you do not want to miss anything. And if you have to spend a tremendous amount of time cleaning up the colon, you're always afraid that you are going to miss things, and so you just don't want to miss anything.
So, and cleaning up means, you jet wash and then you suck out the residue. Well, sometimes that plugs the scope. You can only take so much residue, and then the scope is useless. So the prep is so important. Let's talk about the nook and cranny and the value of the getting a good view. The latest stuff about this is that the right side of the colon is where the cancers are most often missed. Mm-hmm. And there was a recent article that talked about the difference between a good colonoscopy is not experience or not, what it is time taken. Mm-hmm. Don't you agree that right side is the toughest area to find and the toughest area to look at, and it takes the most time, and it's the difficult part of the test?
Yeah, that's the hardest area to deal with. First of all, it's difficult to get there sometimes. Second is that most of the lesions over there tend to be small. They can be flat. They're harder to recognize, and so it's harder to deal with lesions on that side.
Yeah, and you definitely have to spend more time coming back and taking your time. I think you can get there quickly to the end point, but you do need to spend quite a bit of time, much more time on the way out, and really looking, visualizing everything.
Okay. Well, explain the basics to me. The colon, we have the rectum, and then the colon kind of goes up on the left-hand side, and then it crosses
the colon goes
over?
on the left-hand side. It does an S curve. We call that the sigmoid. S.
S. Oh, cool.
Right.
Cool.
And then it goes. There is the descending colon. If we start on the right side, that's the cecum, and then you go ascending to the liver edge, and then across, which is called the transverse, and then the descending, which is on the left side, and then a sharp S curve, and then into the rectum.
Okay, so the right-hand side is like all the way over there.
The ascending colon is
okay.
the area. And there's that curve around the hepatic flexure where you're going around that corner.
That's another big word that I don't know.
Hepatic flexure, the liver curve.
Okay, I'm learning.
And you're having trouble getting around that hepatic flexure, and then you'll be coming out, and then suddenly go flip, and you're into the transverse, and you didn't get a good view. You need to go back. I remember one time I went past there, and so I went back, and I went past there again, and I'm fine. Except I thought maybe I saw just a flicker of something, and the tech was saying, "Nah, we're fine." And I go back again. Oh, what's this? Oh, a cancer. Hidden right on the other side of that liver. Turn. That's where,
We try, the best statistics, we're going to catch 93% of all colon cancers, but they can be very small little cancers on that right side that a person can miss if you're not spending your time looking for them.
I think the most recent recommendation is exactly as you said. Time coming out is what a good indicator of colonoscopy, and just for reference, 6 minutes is sort of what people are recommending now. So.
Okay. Well, we've got questions coming in already, or are there more? All right, we'll dive in. A question from Miller. If you take a baby aspirin every day, can it reduce your risk for colon cancer?
Chris?
Well, it's controversial. So some studies do say yes, some say a full dose aspirin. Some say a medication like Celebrex, which is a specific type of kind of an NSAID or non-steroidal type anti-inflammatory. So I would say with individuals who have a family history of colon cancer, we might seriously consider having a full dose. But there has been one recent study saying baby aspirin.
Okay.
At that New England Journal of Medicine article, where there's back-to-back 2 articles, both saying baby better than a full. But there's controversy in every science. I go baby. And, I go baby for the heart, and then it preserves the stomach. So
That's right.
50, you get a baby aspirin unless there's a bleeding problem. For me, as a rule. Any comment?
Yeah, no, there are potential benefits with the heart as well, and the problem with aspirin and all those sort of environmental factors, if you will, are that they're so hard to pinpoint one thing as being a benefit or not, and so it's real hard to tell. But I think as near as we can tell, there's some benefit.
Okay. Well, what you mentioned, what we know and what it's hard to prove. What do we know about what can reduce a person's risk for colon cancer?
Right. Baby aspirin.
Baby aspirin.
I mean, they used to say high fiber diet, but that's great for colon. That's great for diverticuli, but it doesn't make a difference for colon cancer.
Really, I didn't know that.
I mean, fat reduction.
Fat reduction, staying lean, you yourself keeping your body mass index down as well. So. Exercise
program.
Right. It's basically healthy living would be the crux of it. Try to avoid red meats, diets high in fiber or high in fats, and try to do diets that are high in fiber. But again, that's all sort of circumstantial evidence. We're not able to pinpoint and say, yeah, red meat causes colon cancer. So that's what makes it difficult.
Yep.
Yeah.
I want a magic pill.
You want
a magic pill, or eat papayas.
We won't have to be here.
I'm just making that up.
Papayas. Did you say that? Did you just make that?
Yeah. Well.
I like my word papayas.
I'm sorry. I better get back to the questions. A caller from Brookings, a female caller. Are there any hormone therapy treatments for colon cancer? How would they work?
Chemo. Cristina, you are probably closer to the cancer. Well, you're with it too. I mean, cancer therapy, Scott. What do you besides cutting it out, which is what you do?
It's pretty
Cut it out.
Yeah. Well, there's chemotherapy after we take out the cancer if they have positive cancer in their lymph nodes. But as far as hormone therapy, I don't know of much. No.
I don't know of any.
Yeah.
Well, what are the steps when, at what point does it go beyond? You go in, I see my family doctor, you do the colonoscopy, you find a polyp, you biopsy it, it's found to be cancerous, then what?
Then I call Scott.
Okay.
And I say, I have taken some India ink and marked the colon wall where that polyp was, so that he goes in there. When he goes in there, he sees that there's a mark where the lesion of abnormal lesion is. You can almost tell that there's cancer or not. I mean, the benign polyps look like benign polyps, and when you've got a cauliflower-looking guy, it turns out oftentimes to be, the tubulovillous adenoma with pre-malignant changes, or it's cancer. And sometimes these are broad enough where, even though they're not defined cancer, Scott needs to take that lesion out because it's going to be cancer, and you can't remove it with the polyp. picker, you know what I mean?
You bring up an interesting point about marking these. Is if we think about colon cancers, they start on the inside of the colon, and it's very difficult to see on the outside of the colon. And so because of that, we need to mark these so that's something that I can see when I do surgery, so we make sure that we remove that entire segment of bowel that's related to it.
Okay.
The tougher area, you know, we can have colon cancers everywhere in the bowel. Is there? I want to get to removing it when it's when it's near the rectum, because that's the hardest area, I think.
Right.
But tell us about what kind of surgeries do you do for different parts of the bowel?
Yeah, so depending on where the colon cancer is, depends on what procedure we do. If you think of the colon solely, it depends on what segment. And the way I decide what part of the colon to take out is based on the blood supply, and then also the lymph node drainage, and make sure that I get a margin on each side of the tumor. So
a margin meaning?
An area that doesn't have cancer in it. And we usually shoot for 5 to 10 centimeters, so approximately 4 inches, 4 to 5 inches, somewhere in that neighborhood, on each side of the tumor. Right.
On each side.
And each side of the tumor. So it's a fairly big segment. Most of the time ends up being a foot or so of bowel that's taken out. So if it's on the right side, we take out the right side of the colon. If it's on the left side, we take out the left side. Almost always we can put the bowel back together, and so people are not stuck with a colostomy. If you think of the cancer of the rectum, that's a sort of a different animal that requires a different surgery, and most of the time we can put the bowel back together, but occasionally we can't, which would require an ostomy.
Tell us what a colostomy or an ostomy is.
That's basically where we bring the bowel to the skin, and then instead of having the bowel movement through the bottom, it comes out through the skin and goes into a bag. I usually tell patients the bag is something similar to Tupperware. So they have an attachment that sits on the skin, and then a lid, which is the bag that goes over the top. And so as the bag fills up with the effluent from the intestines, then they go and empty it in the toilet and put the bag back on, just like Tupperware.
Just an absolute amazing thing to me when I got into medicine to realize how many people have this. They live silently in our world. They do just fine. Some of the people who had bad colon diseases end up with an ostomy, and they go, my gosh, I have a life again. So a colostomy is certainly not the end all. I mean, you know, we can certainly live without our rectum. There's a joke there about darn near killed them, but we're not going to go there.
We won't. Okay. Well, I'm going to hijack the conversation. We're going to go back to tape. Now, you've heard the doctors talking about colonoscopies, and right now all will be revealed. With a big thanks to the patient and a big thanks to our medical editor, Dr. Rick Holm, you're going to be able to see what this exam is actually like. Dr. Holm performed a colonoscopy on a 44-year-old man who had a few symptoms that led to a recommendation for this exam. And without further ado, here's a first-hand look at a colonoscopy exam.
After prep, the person's cleaned out. You know, that's the most important step. We're able to pass a scope that's about 6 feet long, and with a lot of maneuvering of gently up the colon, up to the very highest level of the colon, which is on the far right, the cecum. You can see where the small intestine connects with the cecum, and you can see where the appendix is in the cecum. And then actually you race up there. I mean, you know, you try to get up there quickly. That's what you do. And then you come out very slowly, looking at the walls very carefully and watching for polyps or ulcers or lesions of any kind, diverticuli. We saw in this gentleman 3 polyps, 2 which we lightly biopsied and just lightly cauterized to kill them, get rid of them, without causing a hole in the wall of the colon. And the last one we just kind of lightly buzzed without biopsying. They were 3 millimeters. You know, 3 millimeters is probably half the width of a pencil. But if you can pick those 3 millimeter polyps or 4 millimeter polyps out, pencil is probably 7 millimeters wide. Then you're doing pretty good. You're getting them early. It was neat that we had a polyp to show. They are little bumps, and if you take a biopsy, you can tell what kind of tissue it is and predict whether there's going to be problems or not. The most difficult part of the colon is that far right side, because, you know, by the time you get to the end of the colon, you know, you've maneuvered your way in, but if you pull out, sometimes that extends the colonoscope in. So, I mean, it doesn't, when you're near the rectum, if you go in, it goes in. If you go out, it goes out. If you're up there, sometimes you go in, it goes out. And you pull out, it goes in. I mean, it's a tricky thing to get it up on that right side. When we come back in 3 years, which is what we're going to recommend for this gentleman since he had 3 polyps, even though they were fairly small, we'll go up again in 3 years and look for more polyps. His day should be not to go to work, okay? He will wake up, he's awake now, and but he's not going to remember much that I would tell him now. Give him another hour or so, he'll start remembering the day, and you know, after supper tonight, he'll probably remember most of what people tell him.
Colon cancer is more common in people over 50, and the risk increases with age.
Doctors, thanks for being here tonight. Thank you for watching. Our show is about colon cancer prevention and intervention. Here in the studio, ready to answer your questions, are Dr. Scott Baker, Dr. Cristina Jensen, and the on-call medical editor, Dr. Rick Holm. Now, here's a statistic that is kind of disconcerting. According to the South Dakota Cancer Registry, 1/3 of South Dakotans who should get screened for colon cancer don't. So that's a lot of people that are in the eligible or the recommended group that aren't getting screened.
Today, I finally badgered my partner, my buddy, my patient, 61-year-old, into getting his colonoscopy. I'm the last one of the sailing club that hasn't had his rear end checked, and I'm finally going to get it done. I mean, you know, you badger them enough, you gotta get pushing. So I think it has to do with encouragement on the part of the physician and the practitioner. You need to try to keep bugging them. If they're not doing it, you know, just ask them again.
Absolutely. You try to decrease barriers to that. I mean, you don't have to come into our office to see us before the colonoscopy. You don't have to make a separate appointment for that. You can schedule it with our nurses, and we'll do that, provided that you have a safe past medical history. So you try to decrease those barriers, and I find that I'll scope the wife, and then after a few months of prodding, the husband will come
That's
in.
Exactly
Yeah,
right. I've
yeah.
seen that a number of times. Yeah. Yeah.
Well, here's a question from Tyler, Minnesota. I have stomach cramps when I go with the Go Lightly prep that I drink before the colonoscopy. How can I prevent them?
Stomach cramps. I don't know. I got so chilled with the Go Lightly in the refrigerator. It might have stopped the cramps because it was so cold, but it gave me the absolute shakes. So I don't know what to tell you. Maybe cooling it, but I don't know what the answer is. Do you have any suggestions, you guys? It's the cramps is what's cleaning you out. You know?
Oh, okay.
So
well, I think there are other preps that you can try next time. Maybe that's
try the
more helpful. Maybe the
time.
mag citrate is less volume.
Okay, so talk to your doctor and tell
try
him.
the magnesium version.
2 questions kind of on the theme of whether or not you need to schedule a colonoscopy. 80-year-old female caller said she's never had any problems. Should she still get a colonoscopy? Never had one, hasn't had any problems.
She's 80 years of age. That's a wonderful question. Some would say, the Medicare would probably say no. They say stop at 80 unless there's been problems. You can do your screening, you start at 50, nothing, 60, nothing, 70, nothing, no more. At 80, but if they've never had one at 80, I mean, I've got viable people who have polyps and they're in trouble, or they have changes and they have lesions that I'm watching. I'm scoping them in their mid-80s when they're viable and active and healthy. Are you?
Yeah, and I agree with you exactly that you probably should be stopping those screening recommendations, but you know, we're in the Midwest. People live till they're 90, they're still driving, so exactly what you're saying, they're very viable. So I think it's a little bit different than, say, a patient who's 75, perhaps in a nursing home. So
right.
Okay. All right. A question. What gentleman caller? He doesn't have insurance. So without insurance, what would the approximate total cost for a colonoscopy with anesthesia and hospital stay be? But it's okay. It's not an overnight procedure, but you're in the hospital for the rest of the day until you're up and at 'em.
You know what I would do? I would call the state health department. There's a special deal that goes for people who don't have insurance. And the other thing is, before you do it and say, okay, and then pay the full price, bargain with the people. You know, the doctor is very attuned to that. The insurance people are generally not paying full price anyway. They've bargained with the hospital and the doctor's office. So do your bargaining.
Okay,
people
so
are very empathetic. They want people to get this done. Did I?
No, exactly. And there are some great programs out there. You just have to look for them. And your primary care doctor can help you out with that.
Yeah. Yeah, the state has a great program right now for colonoscopies, screening colonoscopies for people that don't have insurance, and they'll pay for it. So
Not all takers, but it depends
right,
upon
there's a need. Right.
Okay.
So
I wish I had the Department of Health phone number. I don't, but if you call your clinic or look it up in the phone book for peer.
But let's say that you have, you're a middle income person.
Yeah.
Let's say you had to pay the whole price of $3,500 or $4,000. Let's say for the whole. Am I in the ballpark? You know, it's the best $4,000. I mean, it's a well worth thing not to have colon cancer. So I mean, nothing. You know, we're used to saying somebody else is paying for it. I want to always have someone else pay for it. Is it worth it? Yes, it's worth it. If the insurance leaves you with $600 left to pay, best $600 you're gonna spend.
That's a good way of looking at it. Okay. Did you follow up?
Absolutely, it's a preventable cancer. I mean, if you're going to spend $600 to prevent cancer, that's a bargain.
Well,
yeah.
We did have some questions here. Caller from Watertown, a gentleman. What can one do to prevent colon cancer in the first place?
And I think that's that lifestyle thing we said, and a baby aspirin and exercise. I forgot to make sure that we said exercise has been shown to reduce colon cancer.
Really?
Yeah.
Exercise. We can encourage people to do walk a mile a day. Yeah. Do it daily, and we'll challenge you to do that.
All right.
And get your colonoscopy.
And then get that colonoscopy. There you go.
That's the big one.
All right, a question from Mitchell. I have a redundant colon and can't do a colonoscopy. Is there anything other than a barium enema that I can do? Now explain first a redundant colon.
Cristina.
Long loopy colon that perhaps someone has struggled trying to get around all those twists and turns.
Okay. So if a colonoscopy isn't really a good option for this?
Well, she mentioned a barium enema, and that's an X-ray study where they put some barium into the rectum and take X-rays. There's CT colonography, which is out, and unfortunately insurance and Medicare doesn't pay for it, so it's still out of pocket. And the worst part is you still have to drink that PrEP. So you can't get around that, at least at this point in time.
And if the CT colonography
shows a polyp,
finds a polyp, then got to go do the colonoscopy to go get it, and another PrEP.
Exactly.
Oh, okay.
So that's why it's probably never going to catch on, I don't think.
No.
I would agree.
That's what's called the virtual colonoscopy?
Yeah.
Okay, so that it's not actually with a scope directly looking at it, it's using the CT scan. Okay. Question from Brookings, gentlemen. Can anal sex lead to colon cancer?
Ooh.
So, is
Scott?
there any...
Not usually colon cancer. More anal canal cancer has been associated with anal sex, and mostly infections related to anal cancer, HPV.
Okay.
But not colon cancer.
Meaning warts.
Right.
Warts down there.
Right.
And the warts can turn into cancer sometimes. That's why it's anal.
Right.
So that needs to be looked at. I mean, you know.
Right.
All right. Question from Sioux Falls. Please explain a flat polyp. Okay, there's different kinds of polyps, so school us on that.
I think of polyps I do as kind of mushroom-like growths inside the lining of the colon, and there's all types of them. Some of them are just like what flat is, just flat within the lining. Some are more of a growth. Some grow on a stalk, and they're called pedunculated. So those are
fun words.
Yeah.
How do you identify the flat polyp? How do you see that?
It's just a change in the character of the wall. You can see there's something different there. It's like lichen growing on the tree. It's fungus
the
once
color's
again.
different.
Color's a little bit
Sometimes
different. You can
slightly lighter sometimes.
Okay.
You get a sense there's something there.
So how would you remove a flat
very
polyp?
Carefully. There's lots of different techniques where we can inject medications to raise that polyp up and then snare it off or kind of lasso off the polyp.
Okay. All right.
The flat ones are tougher because you know, you have to realize that 3 out of 1,000. Now, I mean, you know, some would say 1 out of 1,000. Some people say 5, but I mean, it's 2 or 3 out of 1,000. No matter how careful you are, even sometimes when you don't remove polyps, you can rupture the wall of the colon, and you need to go in and get that fixed. Call Scott and say, well, there's a ruptured colon. But doing the flat polyps, you're right up against the wall, and you buzz it too hard with cautery, and there's a hole. And then you have a hole in the wall of the colon, and you get into trouble and need to have surgery.
Yep.
Okay.
So that's a complication we should talk about and realize that it's real. It happens a percentage of time, no matter how good and careful you are.
Take it away right now. Talk about the risks of colonoscopies.
I quote my patients, serious complications 1 in 1,000 with risks including infection, bleeding, which could require a blood transfusion, a reaction to the medicines we give, and then the feared complication of making a tear. But I give 1 in 1,000 as my rate of any major complication associated with a colonoscopy.
How does that compare to how many in 1,000 do you find cancer? And
I find polyps, the number of precancerous polyps, 15% of all women for screening colonoscopy will have a polyp, and 25% of all men.
Okay. Do men just flat have a higher rate of colon cancer?
Yeah, there's a slightly higher rate of colon cancer in men than women.
Okay. And are they less likely to get screened? Or
well, that's right. That's part of the interesting aspects of the data. Is it because they come in later? It's because they don't get screened? We don't know.
Okay.
For 4 years, I took a record of every colonoscopy I did, the indication, whether there's bleeding or not, whether I found a polyp or not, whether there was cancer or not, what symptoms did they have or not have when they had cancer. And I guess my summary, I mean, we talked 15 or 20%, but this was earlier before everybody was doing screening. Primarily what we were doing was when people were having symptoms. And we were catching up with the screening, recommending screening, but people weren't getting as many of that. We were mostly going after symptomatic. Fully 1/3 of the people I was scoping had significant polyps. And I was finding 3 cancers or 4 cancers a year. I think the numbers are less now. I'm doing the same number of colonoscopies. But it's 20% anyway, I think, that you find polyps. And you know, if you talk about how small, well, you get to this certain level, you leave them alone, come back. But we say 10 years if there's nothing there, 5 years if there's 1 polyp less than a centimeter size, which is a little bit wider than a pencil width. And if there's more than 1 polyp, no matter what size, then you're back in 3 years. Anything different?
Nope.
Okay. The good folks in back did us a favor. They dug up the phone number for the South Dakota Department of Health if you want to contact them to find out more information about colon cancer screening and see if you're eligible for a program to assist. You pay for that. The phone number for Department of Health in state is 1-800-738-2301. Again, the South Dakota State Department of Health, 1-800-738-2301. So give them a call tomorrow if you're interested in that. Now, this is sort of, you just kind of answered this. A gentleman from Brookings a year ago had a colonoscopy. 6 polyps were found and were taken out. How long should he wait before having another colonoscopy?
It depends on the types of polyps. And if they're the precancerous kind, we should be doing it sooner rather than later, so probably that 3-year range.
Okay.
Yeah, I would agree.
All right. A female caller would like to know about tubular edema. What is it, and is it worse than an ordinary polyp?
Tubular adenoma. Talk about the different types of polyps and levels of severity.
Yeah, there are multiple different types of polyps. One being a hyperplastic polyp, which is essentially a benign polyp that is not a precancerous polyp. Then we go to things such as tubular adenoma. I think you spoke earlier of tubulvillous adenoma, and then villous adenoma. And that's really the composition of the polyp, what cells are present and how they form. As things become, a tubular is of those 3 probably the less aggressive, villous being more aggressive. And really it's a histology or a cellular makeup that determines those polyps.
Okay, so if I think villous, villain, more aggressive.
That's
the way to go.
Yeah.
I have to look. I can't keep up with you guys. I got to do that.
And the size of the polyp matters too.
Now, in the piece that we saw, you said they're very tiny, usually.
3 or 4 millimeter, 4 millimeters, how I put it. And you can tell by the size of where my pinchers are, how big the pinchers go out, 7 millimeters and so.
And the pinchers are smaller than like a pencil eraser.
There's a wide, when they're wide open, is the width of a pencil.
Okay, so that's pretty darn
small.
Okay. A question from Brookings. Female wants to know about nanotherapy, where they take tiny particles of gold and it cooks the colon cancer. Are you familiar?
Ever heard of gold nano things?
Okay.
No. Never heard of it. What about some people talk about cleansing enema therapy for evil humors and bad things, and to cleanse you. And I know that all the thing in California. What do you think of that, Cristina?
I think, first of all, I get the call from family members. I just saw this infomercial about I need to have
an
enema, or I need to, and the answer is no. Our body does a beautiful job of regulating itself, so no, we don't have to do that. And don't waste your money on that.
They put all sorts of things that are in that enema that supposedly help, maybe flecks of gold or something, but that's probably not anything that we have any scientific data to say has any value.
Right.
Okay. All right. Switching gears again, a caller from Brookings. Gentlemen, I am on 60 years old, due for his 10-year colonoscopy, on daily warfarin for, I'm not sure the writing there.
Fib.
Yeah, and I want to know if I need to stop taking this for my colonoscopy or if it will prevent them from removing polyps. Now, that's a blood thinner, correct?
Right, and I'll say this, that if it's a heart valve, we do what is called, we drop the Coumadin and go heparin until the day of the procedure, hold the heparin, do the procedure, put them back on heparin, and then put them back on Coumadin, unless there's a bloody thing and we have to, compromise as well as we can. If it's atrial fib, I just stop the Coumadin and give them 5 days rest, do the procedure, and then depends upon what you find, how soon you start it again. What is your take?
I agree with you. 5 days prior as well. Or we use Lovenox as well for that bridge.
That bridge, we call it.
Yeah.
Okay.
Another interesting thing that comes up in my clinic a lot is people are on aspirin. We talked about taking baby aspirin, and you do not need to stop the aspirin to have a colonoscopy. So, just the blood thinners.
Now, are there other things that like when for women, is there a special time of the month when you should schedule your colonoscopy?
Nothing that I can think of. I mean, menopause, menstrual cycles, or that doesn't make a,
Doesn't make a difference. Just do the prep and do that right.
Yeah.
Okay.
You want to go clear liquids before your procedure, so that you're not eating food. And we like good food for the months and years before the colonoscopy, fiber things that are good for you.
Yeah, I'm sorry, talk again about dietary factors that can affect colon cancer.
Yeah, I think a healthy diet, avoid if we can things like red meat, fats, and eat a lot of fruits and vegetables and get your exercise. Again, that data is all sort of speculative, I guess, at best. We don't have a great pinpoint. We can't say, gee, that apple made your colon cancer go away or not come.
I'll make a comment, however, that's pretty speculative, and I'm a fan of red meat. This is South Dakota, and we have really good beef in this state. But a leaner beef is a good thing, and so we would encourage a leaner beef as a regular basis, and good South Dakota leaner beef, We have good beef here. Absolutely.
Okay.
Best in the country.
Best in the country.
Absolutely.
All right. Well, on that note, we're going to give our guests and you just 30 seconds to wrap things up. You got any parting wisdom that you want to share with us?
Well, be healthy. Get your colonoscopy, and if you have a cancer, get it taken care of.
Okay. And Dr. Hill Jensen?
Yeah, that colon cancer is curable, and getting around that major or minor embarrassment factor, it could save your life. So just get out there and do that colonoscopy.
Okay. The embarrassment factor, Dr. Holm, you guys have seen it. It's no big thing for you.
Get over that. I mean, that's something that younger people have as we get older, 50 years of age. Forget it. The nurses, they are all used to all of that. Forget it. And by the way, you get in there, you're all covered up. They put a nice warm blanket on you. You suddenly are off in La La Land, and the next thing you know, you're taking this grand nap upstairs, and it's all done, and nobody's upset, and nobody thinks another thing of it. Right. So get over that. Okay. Thank you so much, both of you,
thanks
for being part
Thanks
of it.
for having us.
Yes, thanks for being here tonight. Yeah. Stay tuned. We'll take a quick break and be back with the homespun perspective and then what's new in medical science.
Looking for reliable healthcare information online? You can start with the resources link at the On-Call website. From there, you can access a variety of accurate and dependable information sources, including the South Dakota State Department of Health and Medline Plus.
By the 16th day after conception, the human embryo has grown into a hollow ball of cells. A fold then develops on the underside of the sphere, pushing inward until the sides wrap around the bend and become a cylinder, starting at a primitive head and extending down to what looks like a tail. The resulting pipe is called the primitive gut, which is evolving into mouth, esophagus, stomach, small and then large intestine. Eventually, this tube will extend about 26 feet from lips to anus. During development, pouches budding out from this food tube will also form lungs, liver, gallbladder, and pancreas. Once the embryo fully develops and is born, the gastrointestinal or GI tract begins performing the marvelous act of digestion. When food is shoved into the mouth, it's gummed or chewed until the tongue pushes it down, passing the entrance to the lungs, which is protected by a trapdoor called the epiglottis, moving the food instead into the esophagus. The esophagus is a toothpaste tube type apparatus which moves the bolus of food into the stomach, where acid not only helps break down the food, but also kills most of the microorganisms that enter with it. The liquefied food then moves into the small intestine, where tiny shag carpet-like fingers provide for the surface area of about a football field to absorb nutrients. The leftover liquid material finally moves to the large intestine, or colon, which works mainly to reclaim water. Also, the colon harbors colonies of good bacteria, which further work on the leftovers, producing an important vitamin, which subsequently is absorbed and used by the body to prevent bleeding. The tube from the lips to anus may not receive the respect it deserves, but it is an engineering masterpiece which humbly nourishes our lives. We'll be right back.
In our medical news tonight, the spice turmeric fits nicely in both curry and tonight's discussion. Researchers at Tel Aviv University have found that a compound in turmeric amplifies the therapeutic value of anti-inflammatory drugs that are used to fight colon cancer. Researchers are already conducting human clinical trials on this, and the scientists involved suggest that the active ingredient in turmeric could someday be taken in conjunction with colon cancer drugs to boost their power to fight this disease. And in other news, about 1 million people in the United States are affected by Parkinson's disease. An interesting new study has scientists looking into how a familiar over-the-counter drug might hold a key to better understanding Parkinson's disease. Researchers looked at data taken from almost 95,000 women and over 37,000 men regarding ibuprofen use. The data was taken from healthcare workers who reported their weekly consumption of ibuprofen and other drugs like aspirin and acetaminophen. Researchers found that after a period of 6 years, the ibuprofen users had a lower risk of developing Parkinson's disease than non-ibuprofen users. This lower risk may not have been due to the use of ibuprofen, and long-term ibuprofen use has risks of its own. Dr. Holm says lots. Things like an increased risk of stroke and damage to the renal system. But scientists involved in the study examining ibuprofen use say that the results are a starting point for further research. They want to know if it was something the ibuprofen did to the brain chemistry, something the ibuprofen users had in common, or something that's completely unrelated that led to the risk in developing Parkinson's disease. And that's all the time for tonight. We're going to wrap things up. Remember, On Call is rebroadcast on SDPB Digital Channel 2, Mondays at 11 a.m. Central and Wednesdays at 4 p.m. Central. Once more, we want to thank our guests, Dr. Scott Baker, Dr. Cristina Jensen, and thanks to our medical editor, Dr. Rick Holm. Thanks to our phone volunteers, and thanks to you for watching and calling in. Have a great evening.
Funding for this program is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Television.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
To learn more about life and health, of The Picture of Health, a beautiful book containing insightful essays and evocative images by On-Call medical editor Dr. Rick Holm and Dr. Judith Peterson. This book, containing healthcare advice, stories of medical history, and meditations on healing, can now be yours for $17 at the South Dakota Ag Heritage Museum. Call 1-877-227-0015 to order. This offer is made by Ag Biocommunications at South Dakota State University.